Hello, everyone. Welcome. Thank you so much, everyone, for joining us today for our webinar, Understanding the Impact of pH on the Right Side of the Heart. My name is Kimberly Brunel, and I am the Manager of Support and Education at PHA Canada. I am joining today's webinar from my home in Mississauga, Ontario. I'd like to just take a moment to acknowledge the lands which constitute the present-day city of Mississauga as being part of the treaty and traditional territory of the Mississaugas of the Credit First Nation, the Haudenosaunee Confederacy, and the Huron-Wendat and Wyandot nations. I recognize these people and their ancestors as people who inhabited these lands since time immemorial, and I'm so grateful for the opportunity to live, work, and learn on these territories. Just a few programming notes before we get started today. We're offering today's webinar in both English and French. So if you haven't already, please select the language that you would like to listen in. If you need some help, feel free to message us in the chat and we can help you do that. Today's webinar is also being recorded in both English and French. So if you want to listen back, if you missed something along the way, don't worry. You can always go back and listen to it again. It'll be posted on our YouTube channel sometime next week. If you have questions throughout the webinar, as always, you can post them in the Q&A box. Do that throughout the webinar. We will cover as many questions as we can at the end of the session. So without further ado, I'd like to welcome our speaker for today, Dr. Jason Weatherald. I'm sure he's not new to most of you. Dr. Weatherald is an associate professor at the University of Alberta in the Department of Medicine and Division of Pulmonary Medicine. He completed his education and clinical training at McGill University, the University of Alberta, and the University of Calgary. He then completed a one-year pulmonary hypertension research fellowship in Paris, France, and completed a Master of Science in Clinical Trials in London, UK. His research interests include risk assessment methods and novel clinical trial endpoints in pulmonary vascular diseases. So without further ado, Jason, I'm so glad you could join us today. I'll pass it over to you.
Thank you very much for the introduction, and thank you everyone for attending today. Please do put any questions into the Q&A box in English or French. The ones in French, I'll try my best to answer in French if possible. This has been some time actually in the making since Kim and I discussed talking about how pulmonary hypertension affects the right side of the heart. I think it's a really important topic, and my objectives are to help you understand the connection between pulmonary hypertension and the right side of the heart so that we can understand the relationship between the right heart prognosis and the treatment choices that we make together. I also want to help everyone understand, pardon me, which treatments can help failure of the right side of the heart in people with PH and why we lack a lot of other treatment options for this complication. Okay, so everyone who's watching and joining will have different levels of background knowledge. So I want to start fairly basic to make sure everyone understands the anatomy of the heart and the lungs. So your lungs sit inside your chest. You have a right lung and a left lung, which are ventilated every time you breathe by drawing in air, which goes through the trachea and then sort of diffuses into the small parts of the lung called the alveoli. And your heart sits sort of nestled between the two lungs in your chest cavity. There's a right side of the heart and a left side of the heart. So blood from your body, venous blood, which has low oxygen in it, comes back to the right side of the heart. And this is pumped into the lungs where gas exchange occurs. So you absorb oxygen and eliminate carbon dioxide. And that oxygen-rich blood is returned from the lungs to the left side of the heart, where it then pumps blood to the rest of your body, and it goes around in a circuit like that. In medicine, we think a little bit more about the heart and the lungs like this, rather than sort of two separate organs. They're really connected to each other, and they sit in sort of a linear fashion like this. So blood comes from the right side of the heart, and that's the separate pump that pumps blood into the lungs, where the small blood vessels called the capillaries are where the gas exchange takes place. And then that comes back to the left atrium of the heart and the left ventricle. So I like to think of the heart as kind of disconnected, like two separate pumps with the lungs in the middle and then the body at the end. When we think about causes of pulmonary hypertension, for instance, this is sort of how I think. I think backwards from the left side of the heart into the lungs, into the pulmonary artery. And so this is a bit more sophisticated now view of the chambers of the heart. So your heart fundamentally has four chambers. You have the right atrium, which is there in blue, and blood passes through the tricuspid valve into the right ventricle. Right ventricle then contracts, pumps blood into what's called the main pulmonary artery. That pulmonary artery splits into a left and a right pulmonary artery to each lung. Again, then gas exchange occurs and oxygenated or oxygen-rich blood returns to the left atrium, which you can see here in red, travels through the mitral valve into the left ventricle, and as I said, is pumped to the body via the aorta. So again, four main chambers. The right-sided chambers are the ones that connect to the lungs. If you want, there's a QR code here that you can scan, as well as a link there that goes to a bit more detail about the anatomy. So a really important fundamental concept is that the right side of the heart and the left side of the heart are not the same. They develop from sort of in utero through childhood completely differently, and they are designed or I guess oriented very differently. The way I sort of try to teach medical students about the shape is that the left ventricle is actually oriented more and shaped more like a football, and the right ventricle is more like a croissant. And on the right here, these are images that are computerized from MRI, but you can see sort of that the shape of the left ventricle in red is a bit more like a cone or like a football, and the right ventricle is sort of draped over it, and it is thinner and broader and is a bit more curved, shaped like a croissant. So these two chambers of the heart, the right ventricle and the left ventricle, the more muscular parts of the heart that pump blood, are very different. So the right side, as you can see on the right, is very thin compared to the left ventricle. And so they share a common thick wall called the septum. But you can see in the right side, it's more shaped like a croissant, but the wall, the outside wall of that muscle is much thinner. And that's because normally the right ventricle pumps against lower pressure than the left ventricle. So the normal pressure in your lung is about 20 over 6 millimeters of mercury. So the 20 is the top and the 6 is the bottom number. That's analogous to the blood pressure that you get when you go to your doctor's office on the arm is usually about 5 to 6 times higher. So it's 120 over 80 would be a normal blood pressure. And so the left ventricle, therefore, has to be thicker and stronger to pump against that high of pressure, whereas the right ventricle doesn't need to be thick to pump against a much lower pressure in health. But what happens in pulmonary hypertension? So as the blood pressure in the lung goes up because of the disease, the right side of the heart pump a bit harder, okay? Initially, the right heart is what we call compensated. It's able to do this. So it's able to contract more forcefully in order to get blood through that mildly elevated pressure circuit in the lung. But over time, like with any muscle training, when you're working against a greater load, the muscle starts to get thicker, but it also starts to dilate. And so what you're seeing here in the image on the left is an echocardiogram. This is an ultrasound of your heart. And the sort of tip of this triangle, of the cone, is where the ultrasound probe is, and it's looking deep into someone's body. And so on the left, you have the right ventricle, and on the right side of the picture, you have the left ventricle, or the LV. What you can see, sorry that the arrows don't quite align, but the right ventricle's width is less than that of the left ventricle in the beginning. But over time, what happens is that the right side of the heart dilates and becomes decompensated. So with that chronically elevated high blood pressure in the lung that the right ventricle is facing, which it's not designed to pump against, it gets bigger, it dilates. Now, when that happens, the valve, the tricuspid valve, which separates the right atrium from the right ventricle, it gets stretched as well. And the leaflets of this valve no longer touch each other. What does that mean? That means that every time the heart pumps, some of the blood doesn't go forward into the lungs. In fact, it goes backwards. And so it makes the heart's pumping motion less efficient because every time it contracts, less of the blood goes forward, more of it goes backwards. And over time, then the right atrium, which is seeing a lot more blood than it's used to because of this leaky valve, starts to enlarge. And that's what we see here in the picture on the right. And this is where we start to get what's called decompensated right heart function or right heart failure, okay? When the right atrium starts to swell up and the pressure goes up in the right atrium, the pressure backs up there into the other organs like the liver, into the abdomen, into the gut, and into the legs. And this is where a lot of those symptoms come from. And at this point, patients with pulmonary hypertension typically will have worse symptoms and start to feel more unwell. So it's really important to make sure we're talking the same language when we're talking about right heart failure. So right heart failure is a syndrome, okay? It's not a diagnosis or a disease unto itself. And a syndrome has components. So one of the main components necessary to call something right heart failure is that we should have dysfunction of the right-sided heart structures, okay? This could be based on echocardiogram, MRI or magnetic resonance imaging, a heart catheterization, which measures function of the heart in some ways, or blood tests such as the BNP or the NT-proBNP levels, which are hormones that are secreted when the heart is stretched. And that this is something that many clinics will do to monitor pulmonary hypertension. So any and all of these can be indicators of dysfunction of the right heart. However, that alone is not enough to call something failure. You can have dysfunction without failure. When we talk about failure, patients also have to have symptoms that are related to the dysfunction of the right heart. And usually we think about the heart as a pump. It's not delivering blood properly to the lungs, therefore to the rest of the body, or it's doing so at the expense of higher pressures on the right side of the heart, which lead to congestion. When I talk about congestion and insufficient delivery of blood flow, what does that mean in terms of symptoms? Well, when you can't deliver enough blood to your organs and to your muscles when you're doing activity, you may feel short of breath, you may feel fatigued. If not enough blood can get to the brain with activity, patients may feel lightheaded or faint. And when that pressure or congestion backs up into the liver and the abdomen, you will get abdominal swelling or fluid in the abdomen and swelling in the legs. So you need both of these to diagnose the syndrome of right heart failure. So why do we care about this? Why is right heart failure so important? Well, it has a strong link to survival in patients with pulmonary hypertension. Not only does it cause some of the symptoms, but it is very predictive of prognosis. So I want to explain what these figures mean. So this is a really common type of way of representing data in medical research called a Kaplan-Meier curve. Really what it's showing is on the left, or the vertical axis, is starting from the top, is the proportion of patients in the study who are still alive at any given time. So patients start in the top left, and then over time, a lower proportion of them are still alive, or in this study have undergone transplant. So then what we do is we separate the population according to the function of the right side of the heart. In this study, this is based on right heart catheterization measured stroke volume index. Stroke volume is the amount of blood that is pumped in each beat. So it is an indicator of heart function. We also use other things like the cardiac output, which is how much blood is pumped per minute. But this is how much blood is pumped per beat. And we separated the groups into 4 different levels. So the yellow line are the people with the highest stroke volume, or I guess closest to normal. These are actually people with normal stroke volumes. And the blue line in the bottom are people with very low stroke volumes. And this is after treatment. So what does this mean? This means that people who don't improve their stroke volume with pulmonary hypertension treatment and remain low have a lower survival over time. If you look at the blue line out to 4 years, only about half of the patients were still alive. Whereas if you look at the yellow line at 4 years, about 80 to 85% of them were still alive. So this means that the function of the right side of the heart with therapy is strongly associated with how patients will do in the long run. This is not just limited to pulmonary arterial hypertension. The right side of the heart is also important in other diseases like left-sided heart failure. If you recall that figure or diagram that I showed of the heart as two separate pumps in a line, the left side of the heart is downstream. So any dysfunction of the left side of the heart can back up through the lungs and cause what's called group 2 pulmonary hypertension or pulmonary hypertension due to heart disease. And that can also affect the right ventricle. So here's a similar curve showing the proportion of patients who are still alive split up as to whether they had normal right ventricular function or reduced right ventricular function. You can see in the red line that a lower proportion of patients are still alive over time compared to those who had normal right ventricular function. So just underlying the importance of the right heart as a prognostic factor in terms of predicting how patients will do over time. So how do we manage patients with pulmonary hypertension who develop right heart failure? First of all, we need to diagnose it, and we need to manage it using multiple strategies. And in really sick patients who are in the hospital, we're doing all of these things at the same time. So starting at the top, we need to identify and treat the underlying cause. So right heart failure may just happen as part of the progression of the disease, but in many cases, it's triggered by something like an infection. A patient with pulmonary hypertension gets a cold, or they get pneumonia, or they develop anemia or low blood counts due to bleeding, for instance, or just inadequate intake of iron. Or they may develop blood clots, which happen to people anyways, and this may tip them over and cause the right heart to fail. One of the first principles that we do is to try to reduce the afterload or reduce the pressure that the right heart is pumping against. So this is what pulmonary arterial hypertension medications, vasodilators, do. But when people get worse, this is usually a situation in which we will add vasodilators, or we may switch to more efficient routes of delivering them, such as putting people on intravenous medications like epoprostenol, rather than or in addition to their oral medications. The other thing we do is reduce the preload or the stretch of the right heart. So when right heart failure develops, not enough blood gets pumped to the kidneys. The kidneys then are actually tricked into thinking you don't have enough fluid in your body, and they hold on to all of the salt and water that they can. And this actually perpetuates a vicious circle where the kidneys retain more fluid, which puts more stress on the right heart, which then therefore does not deliver as much blood to the kidneys, and people can go into kidney failure. This can be treated or addressed by using diuretics or water pills, such as furosemide or Lasix. In severe cases in the hospital, it may require temporary dialysis in order to remove all of that fluid. The other thing we can do is improve the strength of the right ventricle. And this is done by medications called inotropes, which are usually intravenous medications that are done in intensive care units that stimulate that muscle to contract harder. The last thing we can do in sort of dire situations is to help replace the system or offload the right heart using types of life support called ECMO, or which stands for extracorporeal membrane oxygenation. It's also known, if you Google it or look into it, as ECLS, which is extracorporeal life support. And in patients who do not get better, we can consider lung transplantation to sort of fix the load on the heart by replacing the lungs and the blood circulation altogether. So I want to compare what we know about treating left heart failure, which is much more common, versus what we have for right heart failure. So in patients who have left heart failure, also known as congestive heart failure, in this table you can see a list of the potential or the proven treatments that improve outcomes for patients with left heart failure. So there's a variety of classes of medications that are used in combinations that have been studied in very large clinical trials. Some are devices as well that improve outcomes, and these are recommended in the guidelines for left heart failure. On the right, you can see all of the proven medical treatments and device treatments that we have approved for right heart failure. There are none. So other than those things I talked about, like escalating pulmonary hypertension therapies, using diuretics, using short-term medications in the intensive care unit, or transplantation, there's really no direct treatment that improves the function and outcome of right heart failure. So this is a major gap in our knowledge and a great need for things. So these are some of the, this is a really complicated figure, but it's just to illustrate that there are potential targets for medical intervention that could improve the right ventricle's muscle function, that could improve right heart failure and therefore outcomes. We can target proteins that exist within your mitochondria. We can think about preventing or improving fibrosis or scar tissue in the right side of the heart. There are things under investigation that target inflammation, which is an important component of the development of right heart failure, and hormonal therapies, which is really interesting because we know that patients who are female are more likely to get pulmonary arterial hypertension, the disease, but when males get it, they don't do as well. And the major reason for that is that the male right ventricle does not adapt as well to pulmonary hypertension and is more prone to failure. So people have been looking at whether hormones have something to do with that and whether we can modify that by addressing hormones. But nevertheless, this is a major unmet need. And to respond to this need, one of the things that's been going on in Canada that you may be familiar with over the last year is this program that we're working on developing called CRAVE. CRAVE stands for the Canadian Right Ventricular Adaptive Platform Trial. The overall aim of this clinical research program is to test new, but also existing or repurposed drugs that could improve right heart function and outcomes for a broad spectrum of patients with pulmonary hypertension who develop right ventricular function or failure. Currently, we're still in stage 1 of this program, so we are just developing a small clinical trial to test whether it's even feasible to run a bigger trial to recruit patients with pulmonary hypertension and right ventricular failure into the trial. And we're also trying to figure out if we can efficiently collect remotely collected data using smartphones and apps for some of the clinical trial data that will be needed to potentially make it a bit more what we call decentralized, so that patients in the trial can participate without having to come into the pulmonary hypertension centers as often, but we need to determine whether this is actually valid and accurate. This feasibility trial is going to inform a much larger trial that we're working on in parallel, which would test several potential treatments that we have in mind versus the standard of care or placebo. And this type of trial design is a bit newer and a bit more flexible, where we can sort of add new potential treatments. And then as we gain data, if a treatment doesn't look like it's working, we can stop it early so that fewer patients are exposed to futile therapies and more new therapies can be added. And this way of doing a clinical trial is a bit more efficient and potentially faster at arriving at conclusions than our standard clinical trial, where you have a drug and a placebo and you're running multiple different trials. One thing I will mention is that Pulmonary Hypertension Association of Canada has really been instrumental, as have patient partners, in informing how this trial should be done and what sort of things we should measure in the trial. I will say that this initiative really comes from patients. We knew that the right ventricle was important, but in this study that we did a few years ago in partnership with PHA Canada and patients, we looked at the top 10 priorities for future research in pulmonary hypertension, and we think that the CRAVE program aligns with 2 of those top 10 research questions, which are what are the mechanisms of right heart adaptation to pH and right heart failure, and which interventions or treatment strategies result in the best outcomes. And since we know that right heart failure is an important determinant of outcomes in pH, therapies that target the right ventricle are likely to improve outcomes. Lastly, we're not the only people or group of people working on this. This is an interesting device that I heard about in January at a conference called the RESCV device. I'll just mention that this is experimental still, but this is an implantable device which works by a catheter-based implantation of a balloon that sits in the pulmonary artery and expands and contracts to help reduce the amount of work that the right ventricle has to do. And this is great because it may be applicable to multiple different types of pulmonary hypertension, and they have implanted this already in a small number of patients with pulmonary hypertension and shown that their physiology gets better. So it is likely to go on to future larger trials that will look at whether or not this is safe in a larger number of people and whether it can actually improve clinical outcomes. which is a really important next step to getting this type of a device to market. So, in summary, high blood pressure in the lungs or pulmonary hypertension puts extra strain on the right side of the heart. The right ventricle is not designed or developed to pump against high pressure, and then with sustained overload, the right heart chambers will dilate and eventually fail. And when this happens, it's an important determinant of outcomes for patients with pulmonary hypertension. And overall, we lack many efficient or effective therapies for this complication of pulmonary hypertension. Thank you very much for attending live today, and to those who watched the recording of this, thank you for your time and attention. I'm happy to answer any questions through the Q&A now.
Thanks, Jason. That was great. I wrote down, I found it really interesting, the potential hormone connection for women with PAH. I think for once, that's maybe hormones are working in our favor for once as females. So maybe that's something I'd like to hear more about. If you guys want to take a chance to pop your questions in the Q&A box, Jason, maybe you can pop the slides back up and I'll just cover those last couple slides that I had there, and then that'll give everyone a chance to pop their questions in there. Thank you.
Oh, sorry, I missed the slides here, but I've said these things. So questions.
Yeah, while you're doing that, I'll just mention, if you haven't already, just a reminder that our national conference is taking place in September in Calgary. We're in Jason's hometown. And if you'd like to join, we'd love to have you there. Registration is still open, so please do so on our website. And then the next slide, I'll just briefly mention that if you enjoyed today's webinar and you want to continue the conversation, join us next week for our PH Roundtable, which is sort of an informal meeting style event where we sort of deconstruct what's happened today in the webinar, and we talk more about what we've learned, and we hear from patients and their experiences in particular. So if you'd like to continue the conversation that we started with Jason today, I hope you'll join us next week, and you can register on our website. So I see some...
I'll just clarify that my hometown is actually Edmonton and Go
Oh, you're in
Oilers.
Edmonton. I always forget. I'm such an Ontario person. I just, you know, you're close enough, right?
Close enough. It used to be in Calgary, but importantly, the hockey team is different. Go Oilers.
So I'm half right and half wrong. It used to be in Calgary. Okay. Okay. Oh, now, wow, they've flown in. Jason, can you see the questions? Do you want me to read them, or do you want to cover them?
Yeah, I can read them out loud, and then I'll click them off as I answer them. So the first question I see is how does BNP fit into all of this? So BNP is a hormone that is released from the heart tissue when it's under stress. It's not specific to the right ventricle. So in people with left heart failure, the BNP goes up as well. But in people with established PAH, where we know that the left ventricle is not the problem, we trend BNP over time. So when BNP is normal, that suggests people are not in right heart failure. And BNP is relatively cheaper and easier to get on a regular basis than things like echoes, and certainly less invasive than a right heart cath. So it is one of the tools in the toolkit that we use to measure how the right heart is doing over time. So as the BNP is going up, we worry that it could be related to worsening pH. But the BNP, if you do the BNP, if you measure it twice in the same day in the same person, it will be a bit different. So there's some variability into it. So we consider trends and also the magnitude by which it increases or decreases, not only in getting worse, but also in responding to treatment. So it is one of the things that we use to risk stratify people, in addition to your symptoms, the 6-minute walk test, echocardiogram, MRI, heart cath. We integrate all of those things, but it is a nice, convenient, and relatively available test that we can follow over time. Next question is, so why are treatments for left heart failure not helpful for right heart failure? Great question. So the biological factors that lead to left heart failure are different than most cases of right heart failure. So in most cases of right heart failure, the problem is pressure overload. That is one cause of left heart failure, but not the only cause. The most common cause of left heart failure is coronary artery disease and after a heart attack. So where in fact a part of the muscle, the pump itself dies and the tissue is weakened because of a myocardial infarction or a heart attack. Other causes include high blood pressure, so hypertension, but also inflammation, myocarditis, viral myocarditis, and valve disease. So those types of left heart failure is caused by multiple different causes, and it triggers other reactions in the body, like increased nervous system activity. And a lot of the treatments for left heart failure have been developed because of those biological processes, which are not really the same in the right heart. And the left ventricle's response to injury is different than the right ventricle in many ways. So, not surprisingly, in many some studies have looked at the exact same treatments in right heart failure, and they haven't really panned out. So one example is beta blockers. So these are drugs that slow down your heart rate and do help the left ventricle recover over time, and they improve survival in patients with left heart failure. There may be some benefits of beta blockers in the right heart, especially when they've looked at experimental studies in animals. Like it may actually have some benefits in the right heart, but when they've been tested in studies, it hasn't really panned out. And part of the reason for that might be because beta blockers slow down the heart rate, and in patients with PAH, they're kind of dependent on that heart rate to keep blood going. And so when you forcefully prevent the heart rate from being able to increase, which is what beta blockers do, at least in the early stages, it actually puts them at higher risk of getting worse. So that story is, I don't think, completely done yet, but a lot of the other newer treatments for left heart failure are being looked at in right heart failure, and including one of the medications we're looking at in the CRAVE pilot, which is a drug called empagliflozin, which is actually a diabetes drug, but it has been shown to improve outcomes in left heart failure whether or not you have diabetes. And so there are also some animal studies that suggest it might be beneficial in right heart failure, and it's pretty safe and well tolerated. So it's one of the treatments that we want to start looking at in right heart failure. Next question is there any promising news from stem cell-based therapies like the SAPPHIRE trial? So the SAPPHIRE trial, for those that don't know, is a Canadian-developed study looking at stem cells that are taken from a patient with PAH and then changed in the lab to overproduce a molecule, an enzyme that increases nitric oxide. And nitric oxide dilates blood vessels in the pulmonary arteries and may be beneficial and improve the health of the blood vessels in the lungs. And so this study, there's a phase 2 study that was unfortunately sort of suspended or stopped because of COVID, and which had implications on their ability to get patients into the study. The results haven't been published yet. So, it was stopped early, but we don't know whether or not there's any signals that it works or not. That hopefully will be, looked at in the near future. And based on that, it may lead to future larger studies. There are some experimental studies also looking at stem cell therapy for right heart failure to sort of improve the ability of the muscle to regenerate, but these are really at the early stage and haven't been translated to human patients yet, to my knowledge, but it is an area of active research. Yeah, next question. Says, a bit confused. If the patient has diastolic dysfunction and therefore ends up with CHF, and you improve the right heart function that inevitably declines, how will improving right ventricular function help, if that becomes possible, since the left side has failed? So, ideally in patients with left heart failure, or diastolic dysfunction being a type of left heart failure, it's a bit different than typical CHF or systolic heart failure. It tends to develop a little bit more slowly and indolently over time because of risk factors. And people are certainly looking at treatments for diastolic dysfunction, and ideally you would improve the downstream problem, the left side of the heart. But if patients develop right heart function, and we know that that's associated with worse outcomes, targeting the right heart may still help a patient's symptoms or outcomes, independent of whether it affects the left heart failure. Ideally, you would fix the downstream problem, which is the primary problem, the left heart. But treating complications of that condition could also benefit patients, especially if they were well tolerated. So I think it remains an important target, but to some extent, you're right. the best treatment would fix the underlying problem, which is the diastolic dysfunction. Currently, we don't really have many treatments that do that. So both would be of great interest, I think. So next question. If the right heart becomes enlarged because of left heart failure, can you treat those people with pH-specific meds? Great question. It's a question that has been looked at in several clinical trials. And, really most of those trials have shown that those drugs don't work. And some of the studies have shown they actually make people worse. So the pulmonary vasodilators we still, I should say, they're not approved for that condition. They're not approved for left heart failure. Doctors, based on discussions with patients and their families, may try them in select cases, especially when the pulmonary hypertension and the right heart failure may be way out of proportion to the left heart failure. And we're maybe concerned that there's two things going on. We may try them in one-off situations, with what I do is with very clear expectations and sort of objective measures of success or failure. But they generally, at least when they've been looked at in randomized trials, which is the gold standard way of showing whether a treatment works, they have not panned out. And the reason for that is probably that with long-standing left heart failure, there's actual changes in the pulmonary blood vessels, and not just in the arteries, but in the veins, which are kind of downstream from where the drugs work. So if you've got chronic left heart failure and you've got thickened pulmonary veins, and then you give a drug that dilates blood vessels upstream, you do increase blood flow into the lung, but there's nowhere for that blood to go. It's blocked. It's kind of like there's a dam downstream, and then the lungs flood. And clinically, this is what we see, is that you give vasodilators to people with left heart failure, they develop flooding or fluid or edema in the lungs. And this may be one of the reasons why the outcomes are not as good. And this has been looked at in several clinical trials, and really none of them have been successful to date. So it's an unfortunate that I think we've been trying to fit a square peg into a round hole, and they've, there's been some rationale to think they might work, but they really don't work. And the next question is probably my favorite question, which is just a statement: Go Oilers. Fingers crossed. Can vasodilators help patients with restrictive lung disease that cause PH? Excellent question. So it depends on the type of restrictive lung diseases. So there's different types of restrictive lung disease. There are ones that are intrinsic to the lungs, like pulmonary fibrosis, which is a heterogeneous or very broad group of diseases that cause scar tissue in the lungs, which shrink the lungs and make them stiff. These people can develop PH. They can also develop a very similar blood vessel disorder that looks kind of like PAH, even in the context of lung scarring, especially people who have scleroderma. Can vasodilators be used? Yes, the exception to that is that there are no approved vasodilators in Canada, and I'm going to explain sort of why that is. There have been some trials that have been done. Oral vasodilators, like the ones we typically use for PAH, have not really worked out in the studies for what we call fibrotic lung disease with PH. They have been tested. Some of them have actually resulted in worse outcomes. However, there is a drug which is not Health Canada approved, which is an inhaled vasodilator that is approved in the United States by the FDA, called inhaled treprostinil. And this inhaling vasodilators makes a lot more sense than oral vasodilators, because the drug gets to parts of the lung, the diseased lung, that actually have intact ventilation, and therefore likely perfusion from blood vessels that are not blocked. So it kind of delivers the drug to where it's best suited. When we give oral vasodilators to people with scarring in their lungs, it can actually make the oxygen worse, and it doesn't seem to work out. So I think inhaled vasodilators are the way to go. I don't know for sure whether that drug will be even considered to come to Canada, but certainly I think if it did come to Canada and get approved by Health Canada, it would then be an option for people with restrictive lung disease and PH. And it does improve, in the clinical trial that looked at this, it does improve symptoms and exercise capacity and clinical outcomes in this trial called the INCREASE trial. But to my knowledge, it's not approved in Europe and not in Canada at this time. So is the ARIA treatment being trialed here or just other countries? So the ARIA is that pump that I showed that's an implantable pump. The initial studies were done in Austria, and I think they've just recently been published, like the very pilot preliminary studies in a small number of patients. I do know the company is developing a larger or planning a larger trial, which will likely be run in the United States, possibly in Europe, and possibly in Canada. I'm not sure whether they'll try to come to Canada or not. I think it depends on many factors, including, ability to get patients into the trial and also the regulatory sort of framework or restrictions in Canada. But if it does, I think it's something that we would let PHA Canada know, if that company is going to run the trials in Canada, and then where it would be run if that's the case. So a question about what type of exclusion factors will be used? How sick do patients need to be to participate? I assume this is relating to the CRAVE trials. So it will generally be fairly sick patients, but we're trying to keep it pretty broad and inclusive to the extent that we can. There are certain factors where including participants with characteristics that would likely result in them dropping out of a trial or not being able to finish a trial, kind of how to say this kind of delicately, can undermine the validity of a trial. Not to say the patient's doing this intentionally, but certain characteristics of a patient may make a trial more likely to fail and not be able to show a conclusive result. So there are certain exclusion factors that will be used initially, and this may even include people who are in hospital right now. So people who are in hospital right now, obviously you would think are the sicker patients, but if they're in hospital right now and they can't get out of the hospital, it's going to be very hard to do follow-up testing on them, or even get them to the 4-month or 6-month mark where we can assess the outcomes, whether or not something is working. So patients will have to be sort of sick, but able to sort of participate in the study. So in general, we're trying to be less restrictive in CRAVE than other trials would typically be. I hope that answers your question. I can't be more specific than that because we haven't really nailed down these specific factors yet, and that study is just under submission to Health Canada for approval, so the factors may change. So next question is high doses of Lasix a good treatment for PAH and diastolic dysfunction? It's a good point. It's a widely used treatment that has actually never been studied in a clinical trial. We just kind of know what Lasix does, and it really reduces Lasix works in the kidney, actually, so it helps the kidneys remove sodium or salt, and fluid follows that through the urine. So it's a way of reducing the total amount of fluid in the body, which is good for a sick right heart, and it's also good for diastolic dysfunction to a point. Diuretics like Lasix, we can overdo it and actually harm the kidneys. And so that's why when we're doing them, we need to monitor kidney function, and they can also make electrolytes deranged. So it can make your potassium level go very low, which can then cause heart rhythm problems and can make people worse. So this is why doctors may be checking blood work frequently if you're on Lasix, and even adjusting the dose up or down based on what we're seeing. So is it a good treatment? I mean, it is a treatment. Saying whether or not it's good is kind of based on clinical experience. There's not a lot of great data that has compared Lasix to a placebo or doing nothing. And to be honest, we've used it so long in so many patients, I'm not sure we could even ethically study that properly. Because we just kind of know that it works, but that's not a great answer. So this is an addition, I think, a follow-up to a previous question. You attempt to improve RV function with research, but if diastolic dysfunction has caused the left heart to failure, is there any reason on improving RV function? Will symptoms improve? I guess that's a good question. No one's really done that study yet to prove that improving RV function in patients with diastolic dysfunction will improve the symptoms. So we know patients with RV dysfunction have worse symptoms and worse ability than patients without RV dysfunction. If you take 100 patients with diastolic dysfunction, if 30% of them have RV function, those patients tend to be sicker, have more disability, more symptoms. But no one's really shown that by making the RV function directly better, that the symptoms improve. So that needs to be studied properly. Is it common to have both a heart and lung transplant because of PAH and scleroderma? So it's not very common. Scleroderma is a bit different than other types of PAH. Scleroderma is caused by sort of inflammation and scar tissue in multiple organs, and so it can attack the blood vessels in the lungs and cause PAH. It can also independently affect the heart directly, specifically the left side of the heart. So it can cause pulmonary hypertension through multiple different mechanisms, and that's why we usually look really closely at the left side of the heart before labeling someone with scleroderma as having PAH. Now, if they get worse, we evaluate the heart very carefully because if it's just PAH, patients don't need a heart transplant, they just need a lung transplant. So the nice thing about the RV, the right ventricle, which I didn't really touch on, is that with transplantation, you can take a patient with a very sick right ventricle, and if it's entirely due to the load or the lung problem, the pressure problem, and you replace the lungs, the right ventricle heals. It goes back to almost normal size and function in almost all patients. So it's very resilient and adaptable, is what I would say. If you can reduce the load on the right ventricle enough, the right ventricle can heal. And this is why we've become more aggressive with PAH medical therapies, using them in combination, because we know if we use them in combination, we're more likely to drop the pressure substantially enough for the right ventricle to improve. In certain cases, however, when scleroderma is attacking the left side of the heart or directly has caused fibrosis or scarring in the right ventricle, some patients might require a combination heart and lung transplantation rather than lung alone. And that is, I would say, a more common question in patients with scleroderma compared to those with, for instance, idiopathic PAH, where we note and assume that the left ventricle is relatively normal. Okay, next question is, I have CTEPH, had surgery in August of 2014, always was very active with exercise, and had surgery at 70 years old. Probably from over-exercise with a personal trainer in prep for knee replacement, which I almost walked out of surgery. Shouldn't exercise be a priority and followed more depending on patients' capabilities? Of course, like all organs, movement is the most important, as in heart surgery. The surgery being basically more difficult than even heart surgery. Are there studies? So I guess I think there's a couple of comments and questions in there. There are studies on the CTEPH surgery that show that it improves outcomes, but it is a major surgery, and does exercise improve things? Definitely. So there are also studies of exercise-based rehabilitation programs for patients with PAH and also with CTEPH, and they improve functional ability and symptoms and quality of life in those patients. So, is rehabilitation before surgery beneficial? I don't think that's really been looked at. And it's precarious in people with CTEPH who have sick right hearts, because exercise, even basic activities of daily living, can stress the right side of the heart out. And we never want to overdo it with exercise in pulmonary hypertension. So exercises has to be done safely, because if people push it too hard, they can have fainting episodes, and that can be very dangerous and even life-threatening. So, certainly movement is important, and exercise is important in the recovery after CTEPH surgery, and is an important part of managing people with PAH as well, who are stabilized on medications. I think we had a talk a while ago on the importance of exercise rehabilitation, and a trainee of mine has been looking at, in fact, we know that exercise works, like exercise is effective. What we don't know is why people don't do it that often. Why do patients with PAH not really participate in exercise-based rehab programs? And it's often due to lack of access or physicians not talking about it and referring them. So I think what we found from this recent study that we presented at a conference recently, and we'll try to publish, is that a lot of patients don't even get asked or referred, or they get referred or they don't have access to it in their community. And that's a big problem. I think we need to, this is not unique to PAH. This is a common across respiratory and cardiac diseases. We don't have access in a lot of communities, and virtual rehabilitation has been developed and is successful and has been one of the great things that's been rolled out through COVID is increasing access to virtual-based rehab. But we still don't have a lot of safety data about that in PH patients who are a bit different than, for instance, people with COPD. So we need to develop studies that show that it's safe to assess patients remotely and then to engage in personal training and exercise training without patients coming in and being supervised. But that's also an area of active research. There's been a small study from Ireland that suggested in well-controlled, well-treated PAH patients that it's probably safe and effective to do entirely remote-based rehab. So very broad question. I hope I answered that question, the different components of your comment and question. Question from Jane. How close is sotatercept being brought to Canada? I don't know. I know that it's been submitted to Health Canada. It's been approved in the United States. It's been submitted in Europe. I think the timeline from what I've read is in the fall in terms of when they'll have a decision from Health Canada. But there's extra steps in Canada to getting a drug actually into patients, which even if it gets approved, it has to get paid for by the governments, and those involve individual, provincial, or even regional agreements with how much sotatercept will cost. And so for public health insurance reimbursement for that drug, that can take a lot longer. So I don't really know where that is that is being done in parallel, I think, but is not you have to have approval by Health Canada to even use a drug in Canada outside of a trial. And then the next step is reimbursement, and which would follow. And in the past with PAH therapies, that reimbursement decision has taken anywhere from a few months to several years, and it is province specific, is my understanding. That might be PHA Canada may know more about that than I do even.
No, everything you said is spot on, Jason.
Thanks. Yeah. The next question's in French. I'll read it in French and also try to translate into English. Est-ce qu'un programme d'exercice, musculation et cardio peut aider dans l'HDAP et est-ce que c'est priorisé? So this is asking, is a exercise program like a weight training and cardio based exercise, can that help in PAH? And is this being prioritized? Great question. I think I kind of answered that with the previous question, is that it can definitely help, especially in stable patients. And is it being prioritized? No, I don't think in most places that I guess access is being prioritized. And I think this is something that maybe we can work with PHA Canada and our clinicians across the country to do is making sure that we're thinking about it when we're visiting with patients, when we're having visits. We're often talking about medications and side effects. And I think we need to make sure that our clinicians are not forgetting about these other things that are proven to be beneficial and bringing them up with patients and asking them, do you want to do this? Is it safe to do this? Can I access this? So I answered that in English. Hopefully my response was translated and clear in French. Okay. Dr. Dorasamy, hi. How do you weigh other hemodynamic parameters on right heart cath, such as DPG, RAP, cardiac index, and SVI? I'm sure a combination of factors are best, but a diastolic pulmonary gradient greater than 7 may indicate remodeling in the pulmonary vasculature. Yeah, this is a great question. So this is for the patients, this is a bit more nuanced. When we do a heart catheterization, we can measure a lot of things, and we can calculate a lot of things from those measured variables. So there's a couple of measurements that are talked about here. The diastolic pulmonary gradient is the difference in the pressure. When we measure pressure is pulsatile, so it goes up when the heart contracts and it comes down when the heart relaxes. And the diastolic pressure is the pressure at the very end of each heartbeat cycle, right before the heart contracts again. And when there's a difference between that low diastolic pressure in the lung and the downstream pressure, which we call the wedge pressure, it's thought to indicate more remodeling in the lungs. Whereas in left heart failure, it's usually normal because it's just I guess early left heart failure because there's a passive transmission of pressure through the lungs. There hasn't been remodeling or thickening of the blood vessels in the lungs yet. And so the diastolic difference is typically low. There's a lot of studies that have looked at that, and some of them show that it's important, some of them don't show that it's not. And the ones that don't are probably due to measurement error, where there's incorrect measurement of the diastolic pressure. Some studies have shown that in left heart failure, it's important. In the recent guidelines, they've kind of, in older guidelines, we talked about it, and then the recent guidelines actually suggest just focusing on PVR because more studies have shown that that's prognostic. So some studies have shown that the diastolic difference is not prognostic, at least in left heart failure. What's important about the diastolic pressure is that it is part of what goes into the calculation for compliance. Compliance is how distensible or stiff is the whole lung circulation. And that's different than the resistance to flow. And it is in itself important. And it's in fact the parameter that ARIA device is specifically looking to target is the stiffness or distensibility of the pulmonary circulation. So this is a bit esoteric, but it is important because these different variables mean different things. So for instance, cardiac index is actually in the study that I did, cardiac index is important. So cardiac index is how much blood does your heart pump multiplied by your heart rate. In the study that I showed, we actually demonstrated that the stroke volume index itself is better than the cardiac index. The reason for that is that cardiac index can be normal, air quotes, but it's being driven to be normal entirely by increases in your heart rate. And that's actually not adaptive or useful for patients to have a heart function that's maintained only through heart rate. So it can be a bit misleading when cardiac index is normal in patients because the heart rate is driving it. So if you divide cardiac index by heart rate, you get stroke volume index. And that we showed in that study that it's more predictive of outcomes. But importantly, the other variable that you're talking about here, the right atrial pressure. So the pressure in that other secondary chamber, the smaller chamber on the right side of the heart, is independently prognostic. So both are important. And so I guess to really answer your question is you need to integrate them all. And we never hang our hat on one variable. If the stroke volume is low and the right atrial pressure is normal, great. But if they're both abnormal, that's bad. That's worse than any one of them being abnormal. And if they're both normal, that's good. So it's integrative is what I would say. So I hope that was understandable to the patient audience as well. Joan, how does a hole in the heart impact blood flow within the heart? Oh, Matt, great question. This is full disclosure, not a cardiologist, but so holes in the heart are often something that we're born with. So congenital heart defects are things that you're born with, and this just happens to a proportion of people in the population. And where the hole is affects the blood flow in the heart tremendously. So there's something called an atrial septal defect, and then there's ventricular septal defects, which are connections between the two large chambers. The ventricles. Atrial septal defect means there's a connection between the smaller chambers. And the pressure differences are a lot bigger between the ventricles, but the size of the hole matters, and the timing of when those holes are addressed matters. So if a lot of these can be detected in infancy or even in utero with ultrasounds, and they can be fixed early on in life. In some cases they get missed or not detected, and in many countries where there's not access to these technologies or physicians, people come to Canada where they're diagnosed later in adulthood. The problem with not fixing holes in the heart is that they can over time overload the right side of the heart with too much blood and pressure, and that increased flow causes PAH in some people over time. And there may be a point to which closing the hole is not beneficial anymore. And that is one thing we try to do with cardiologists is figure out when should we close the hole in the heart, either with surgery or with devices, and when is it too late and not beneficial to close them. Interestingly, not really done much in Canada at all, but in some countries, creating a hole in the heart is actually a palliative approach for people with right heart failure, because when the pressure gets so high, if you introduce a hole between those two small chambers, the atria, it kind of acts as like a pressure release valve for the right heart. Now, it has a cost. It makes people's oxygen go very low, but it can actually improve their symptoms and ability to function temporarily. So when I say palliative, it's done to try to improve symptoms. It doesn't necessarily improve lifespan, but it may make patients feel better, but they often need more oxygen to compensate for that. So, and that's why we don't close those holes in people who've already got established severe pulmonary hypertension.
Mm. I think we've got time just for one last question, Jason, if you want to
Sure.
choose the next one or if you want to pick from the list, but one
Yeah,
more.
I mean, I think this next question I think is probably on everyone's mind, and I'm happy to comment on it. So, can I comment on the effectiveness of sotatercept? Yes, I can definitely comment on that. So, sotatercept is for those who do not know, it's a new potential treatment for PAH. It's different than our existing PAH therapies. The existing therapies that we have are mostly blood vessel dilators. So they open up and dilate blood vessels to lower pressure, which improves exercise capacity and symptoms through a variety of mechanisms. So sotatercept is completely different. It works by targeting the abnormal remodeling in the lungs. So it binds these growth factors called activins, which activins promote the development of PAH and progression of PAH by stimulating growth of those blood vessel wall, and so making the blood vessels thicker. So if you block activins, that proliferation may stop or even get better. So it may actually reverse to some extent the disease. Now, I say may because it really hasn't been demonstrated in humans yet. In animal studies, it reverses some of the pulmonary vascular disease, as have several other treatments that we've tried, but that didn't pan out in humans. But it's thought to potentially reverse remodel through affecting growth factors that do this. So clinically, what does it do? So in the phase 3 trial of sotatercept, so it's a clinical trial where patients were either on a placebo or sotatercept. It improved exercise capacity on the 6-minute walking distance by about 40 meters, which is clinically meaningful. We know from other studies that any therapy that improves walking distance by more than 30 to 33 meters is clinically relevant. So it's associated with better outcomes and better symptoms and quality of life. So a 40-meter increase is meaningful. And then the secondary outcomes in that trial were almost all met and improved by sotatercept, including functional capacity or symptoms, 2 of the 3 measures of quality of life. It reduces BNP, and importantly, it improves hemodynamics and improves right heart function. And then I think probably most importantly is it reduced the risk of clinical outcomes, which was largely driven by people getting their PAH getting worse. But the size of that effect was huge. It was 84% reduction in the clinical worsening or death, but really driven not by differences in death, but by clinical worsening. So it causes clinically meaningful improvements in a variety of domains in people with PAH, and this was done on top of people on background therapy. So I can't remember offhand, but I think about 2/3 of the patients were on triple therapy, and then another third were on double therapy, and about 40% of them, if I believe, were on epoprostenol or treprostinol, pumps. So a large proportion of this was a heavily pretreated group of people who then further improved with sotatercept. So in at least in the clinical trial population, very effective. And of course, we never consider effectiveness without talking about safety. Relatively safe. Definitely, there are some signals that that it does have side effects. Of course, it can cause these new blood vessel growths on the skin called telangiectasias. And there seems to be an increased risk of bleeding, especially nose bleeding, but potentially also bleeding internally in the stomach, like gastrointestinal bleeding. So that's an important thing that we're going to need to watch out for if and when that drug is available.